Thank you.
Okay. Thank you. Ms. Green, I'd like to clarify a misconception, and thank you for highlighting the difference between abuse in people with dementia, which is a minority of older adults. People who are demented, most older adults don't have dementia. This study that I'm about to talk about is only focused on community residing older adults who clearly could give informed consent to talk to us. So one would say that their dementia was limited if present at all. And the iceberg analogy should be inverted. Elder abuse is in the community at a far higher rate than we thought, and whereas institutional remedies are the solution for elder abuse in nursing homes, meaning environmental and structural and staffing remedies, we have no idea either what the effects or the remedies are for community residing elder abuse, which should be particularly disconcerting to you because that 1 in 10 figure you cited, that's community, and that doesn't count financial. Then it goes up to 14. So we did pull that financial out. So you highlighted exactly what I wanted to highlight, and I wanted to say that again and really clarify. This is in the community. This is our research team. Goals, I was asked to limit it not to go into conceptualization, risk factors, my ideas, which is going to be already, as you can see, hard for me. But big study, 5,777 people, NIA and NIJ, we basically pooled funds, did it, and then asked them if we could, because that's how you get the yes. You ask for forgiveness. And it worked out very well. Older adults are great to work with because they want to help, and the cooperation rate was very high. So 60% women, 40% men, average age 71.5 years, 85% white. So this is basically a good U.S. representation. The data I'll show you were slightly weighted to fit our population parameters and gender a little bit better. What did we look at? Just to characterize the sample, I want to highlight a couple of things. They are not terribly wealthy, and they don't have great social support. And consistent with 4 other epidemiological studies of younger adults, about a 60% prior traumatic event. This could be a disaster, prior assault, something that meets post-traumatic stress disorder criterion A, meaning something really bad happened to you. This is the context of this country. We live in a country where more than half the people experience a traumatic event in their lives. I'm going to be talking about all forms of abuse, and I have the definitions not to read them, but in case anybody asks me to mail them the PowerPoint so you know. We took I guess what you could call a deconstructionalistic approach to defining elder abuse, which means if you all decide later on that one of these things shouldn't have counted, we can pull it out and give another prevalence because we asked these individually. First one is emotional. I define this basically as if a police officer overheard this happening, he or she would have to intervene. That's the level that we're looking at there of verbal types of things. And overall, past year is 4.6%. That's another thing, that when we cite this 1 in 10 figure, that comes from this study, and that's past year, not since age 60. So if you want to look at elder abuse during the time that you're an elder, it's way higher. It's disconcertingly higher. Those are the individual subtypes, but we're looking at about 4.5%. An even split between men and women, so it's happening at about the same rates. Who's doing it? Well, I'm not a believer in saying it should only be the trust relationship. You can define elder abuse that way, but I'm talking about elder mistreatment. The reason is risk factor for stranger assault and risk factors for caregiver assault or familial assault overlap, and one can be a risk for the other. To blind yourself to half of it is going to make the remedy or the intervention more difficult to design. So anyway, take-home point from this slide, I tell the med students when I give this talk, the pathogen is in the environment. It ain't strangers. It's somebody in the person's environment that's doing community residing elder abuse. That's obviously the case in institutional elder abuse because they're in a confined space. It's also the case with community residing elder abuse. That will inform an intervention. I'm not supposed to talk about risk factors, but I will talk about one, low social support. That's a common theme. That speaks to the intervention that we're going to need to do or the preventive intervention. Physical mistreatment. This is really bad aggravated assault, basically. This is a definition for aggravated assault. Now, we use this for younger adults and children in our national studies from our center, and you're exactly right. This follows the child and young adult. Finally, we're getting around to doing it with older adults. We defined it similarly. Much lower rates, thank God, for past year and even since age 60, but still not zero. About 1 to 2%, slightly more men than women. This is expected. Same thing in younger adults. Who's doing it? Guess what? Community residing elder mistreatment is domestic violence. And not only is it domestic violence adult on adult, which is domestic violence, so this includes kids and spouses, but for women it's spouses, it's partner abuse. So that conceptualization of domestic violence may well inform what we do for older adults. And it's really a lot for men too. That's for physical. Oh look, low social support again. Sexual mistreatment. Now this one's hard to get people to talk about. Nonetheless, people did talk about it. This is basically rape or significant sexual assault. Those are the parameters. 0.6% past year. There's a little bit of that since age 60 flip because you have to ask people, since age 60 has that happened, and we can't get that on a very low incidence thing, that exact, did it happen this year or the last year type of question. More women than men. Again, this is consistent with younger adults. Who's doing it? The N is small, so we don't really want to put too much money on who's doing it, but you should see that partners and people in the environment, the pathogen is still in the environment for my CDC buddy here. This means in community residing elder abuse, the people who are doing it are with the person. And remember, we asked about strangers. Now that might, in the caretaker type of definition, that's required. But if you're looking at all violence toward older adults, which is what I think we should be looking for, it's the person that they live with. And this is for people who can move, right? Low social support again. Neglect. Now we define neglect in a couple of ways. I'm going to talk about potential neglect. Definite neglect is somebody who had a need and an identified person to fulfill that need, and yet it wasn't being done. Potential neglect is an identified need, a significant need, that they may or may not have anybody to do that for. So still, this is a person who, you can call it self-neglect, you can call it institutional neglect, you can call it societal neglect. It's an unmet need. And these are basically needs of daily living. Potential neglect, definite neglect, we know it's happening, is 0.5% of community residing elders. And who knows how long they're going to be able to stay in their residence in the community with this level. But potential is about 5%. And slightly more women. It happens to slightly more women. And the perpetrator, obviously, we don't have a category because it's, by definition, the caregiver. And low social support, that goes without saying. If you're being neglected, you don't have too much social support. And then financial. And this one, I think there are better ways to do it than we asked. It's very hard to get people to pin down exactly when it happens and exactly how often it happens, because it tends to be something that's going over time, and it is, in fact, a theft. So it's often hidden. So I would consider these numbers fluctuating. That's our definition, in case anybody asked me to mail them the slides. But overall, about 5% from family members. And this is only family members. I've taken out strangers because it goes much higher, and it's even harder to define the timeline. So those are the prevalences. Again, social support. And I'll talk about what I mean by social support in a second. And I just threw a lot of numbers at you, so I'll do it again. This is the summary of the numbers. And if you have any type of mistreatment in a community residing adult without dementia, you're talking about 10 or 11%. Okay. If you pull out emotional, if you really don't like that emotional thing, if you think, well, you know what, talking angrily and threatening to kill somebody is not really abusive, it's just frightening, then you're around 7 to 6.5%. It's still extraordinarily high. Now, multiply this by the community numbers versus the number of people in institutions, and you see the proportion of mistreatment in community residing adults compared to that in institutional residing adults is extraordinarily large. Yet, a lot of our focus, and I don't want to take any focus away from the institution, but I'm saying we have a partner problem here that we assume is institutional based or by caregivers, and it's domestic violence in the community in a lot of these cases. So those are your overall numbers in the breakdowns. Social support. Now, when we want to talk about preventive interventions, and I'm not supposed to go too much into that, so I'm just going to set the stage, because if you hear it 6 times, you'll remember it better than if you heard it 5. And I think other people are going to say the same thing. Social support is social connectedness, connectedness to the community. Isolation could be the opposite of that. If you want to set up an abuse environment, put a person in a situation where other people don't know about them. Disconnect them from family, friends, and society. For kids, we call that grooming. We call that, for domestic violence victims, we call that grooming. For older adults, we call it, well, they're older, their friends are dying, I don't really have time for them, that type of thing. So if a person is isolated, if a person is disconnected, then they're more likely to be abused. I'm talking about a community residing person. So the remedy is going to be to enhance those community connections. Now, what's another correlate of growing older? Diminished capacity for transportation. Obviously, that's the right. So public transportation, Charleston, South Carolina, we have buses, right? It's 101 degrees. You cannot wait at the bus stop for 20 minutes for a bus. So I should amend my things to say something like senior-friendly transportation. And that's one area I think that we can really focus to enhance social support, and that will enhance prevention efforts. Because if a person's not isolated, it's less likely to happen. My final take-home point, this will be the first time in the history of any presentation I've ever given that I'm under time. What don't we know? We know the numbers now on community residing older adults. There's been some replication studies by other groups that have come in really close, particularly when you match up the questions. So we know it's a significant problem. It blows the doors off a lot of problems, and Sid Stahl is going to emphasize this in terms of its occurrence. But we have not answered the so what question. Now, I did a big study after the Florida hurricanes in 2004. Remember when they got hit by 4 hurricanes? Bam, 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 bam. And everyone thought, oh my God, the older adults are going to be, they're twitching, it's going to be horrible. Well, guess what? Older adults did a hell of a lot better than younger adults after that in terms of their emotional outcomes. Now, if you were directly affected, obviously they were physically more frail, but they dealt with it a lot better than younger adults. It could have been all the younger adults who would have been stressed out. Older adults already had their heart attacks and died. But in reality, older adults have wisdom, they have experience, they have coping mechanisms that they can call on. So if we give them the resources that they need in the form of social support, they'll probably do okay. But we don't know. We don't know what types of elder mistreatment lead to more mental health problems, depression, post-traumatic stress disorder, anxiety. We have no idea because those studies haven't been funded. We have no idea what are the risk factors. We now have an idea of what are the risk factors for abuse, but what are the risk factors for negative outcomes? If you combine 2 forms of abuse, does that hit the ball out of the park and this person is going to withdraw? Oh, wait. Withdrawal is a symptom of post-traumatic stress disorder. Isolation is a symptom of increased victimization. So mental health effects might facilitate and exacerbate additional abuse because they set the person up for more risk factors. We don't know. And I'm going to task the political type people in the room to sort of give the agency heads a hint. NIA thinks, well, it's a mental health problem. It's not my problem. NIMH thinks, well, you know, that's really an NIJ issue. NIJ doesn't deal with mental health outcomes. Do you see the circular problem we have here? So now we're starting to find out how often it happens. But if we really want to intervene, if we really want effective remedies, we need to know the so what, both in terms of dollar figures, but more importantly in terms of human suffering. And we're going to have some talks about the health outcomes in institutional settings. I'm also interested in the mental health outcomes, which drive a lot of the health outcomes in the community. So, take-home point, interpersonal violence against older adults happens a lot. A lot of it is caregiver violence or family violence. About 10% if you don't count financial mistreatment. Social support's a common theme or lack thereof, and we don't really know what the remedy is going to be until we know what the outcomes are. That's it. Thank you.
Thank you very much, and we will follow with Ms. Yen.